Thank you, Valentina. I'm going to invite Dr. Roy to the stage for our Q&A session. So I'm going to start the first Q&A. I think it was the question from the audience. This is for Dr. Roy. What's the difference between ulcerative colitis and Crohn's disease, and are there special considerations for Crohn's disease and PSC? Thank you.
Yeah, so I mean, the difference between ulcerative colitis and Crohn's disease, they both fall under the umbrella of inflammatory bowel disease. It's very much the anatomic distribution of the inflammation and in many ways the characteristics of the inflammation. So for ulcerative colitis, like I mentioned, inflammation is typically superficial on the inner lining of the colon. It starts in the rectal area and moves up the colon in a continuous fashion. Again, in PSC, there is this unique phenotype where patients' rectums may be spared or there might not be very much inflammation there, and they have predominantly right-sided inflammation. As opposed to ulcerative colitis, Crohn's disease involves inflammation in any part of the GI tract. Could be from the mouth all the way down to the anorectal area. That inflammation is not a superficial process, it's more of a transmural process, meaning the inflammation goes through the entire thickness of the bowel. And that's why we sometimes see complications like abscesses forming outside of the intestines. Crohn's disease also can stricture, meaning the intestines can scar down, which leads to intestinal obstructions. There's perianal manifestations like abscesses, fistulas. And so it's really the anatomic distribution and the extent of inflammation. With regards to special considerations for PSC and Crohn's, I think making the diagnosis, sometimes when we see just the right-sided inflammation, I think sometimes we think of more Crohn's disease rather than ulcerative colitis. And so knowing that a patient has concomitant PSC, I think, is important. The main treatment difference there would be, for ulcerative colitis, we will often start using therapies like oral mesalamine agents or topical mesalamine agents, suppositories and enemas. Those have been shown not to be very effective in Crohn's disease. And so that is the one situation in which making the distinction between Crohn's and ulcerative colitis may be important because it impacts therapy. Otherwise, all of our biologic therapies, small molecule therapies, all of those, generally speaking, are FDA approved for both Crohn's and colitis. And so the treatment decision making is quite similar.
I think one point to add to that, which I didn't mention earlier, is overall, like the data from the International PSC Study Group has showed that patients with Crohn's tend to have a better prognosis compared to patients with ulcerative colitis. That might have something to do with the gut-liver axis. And sometimes when you have patients with active colitis, we tend to see what we call pericholangitis or inflammation in the liver too. I think that could be a reason. So Crohn's, a little bit better prognosis compared to ulcerative colitis and PSC. Brian, any online questions?
Yes. So another one that came up, and I'm doing my best to address them chronologically, is the role in IBD post-transplant, the role of immunosuppression protocols and how that may interact with IBD medications.
Yeah, I mean, post-transplant, purely from an IBD standpoint, often we will tend to work with the hepatologist to figure out what regimen works best for the patients. I think it is important to make sure if a patient has needed a biologic therapy or a small molecule to get their disease controlled from an IBD standpoint, often we would hope to continue those medications in the post-transplant period, although there will be heightened awareness of infections and other complications as they go on other immunosuppression for the liver.
So in reference to the silent inflammation with IBD, is it generally recommended that that's treated with biologics and such to reduce the risk of cancer, of colon cancer, or if there's not symptoms, it's not? How is that usually addressed?
That's an excellent question. So in the world of IBD in general, I think historically, going back many decades, the philosophy was to treat symptoms when we didn't have so many medications available to us. Now, Really what we're striving for in the world of IBD is this concept of endoscopic remission. So not that just a patient is feeling well, not that their blood tests or their fecal markers of inflammation have normalized, but we really want to make sure when we are doing colonoscopies, the inflammation in the colon has healed. So in patients who have quote unquote silent inflammation, where there's no symptoms but ongoing inflammation in the colon, we will continue treating that, trying to be aggressive, stepping up therapy to really achieve mucosal healing, because that's when we know patients are at the least risk of having flare-ups, needing steroids, ending up in the hospital, needing surgery, or developing colon cancer. So even in patients without symptoms who have objective inflammation on a colonoscopy, we will continue treating that.
We also have Dr. Medici online, so you can also ask questions to her as well. Anything online, Brian?
Yeah, another follow-up on the topic of colonoscopies, also post-transplant. Do we still recommend annual colonoscopies for colorectal cancer screening post-transplant? We're seeing nods. Yeah.
Yes, I think we would continue the intense surveillance given the heightened risk of colorectal cancer.
A question for Dr. Medici in the meantime. Do you have any recommendation in terms of diet for patients with PSC with IBD versus PSC without IBD? Are there any special considerations in terms of diet?
I was, nothing that it's formally published. So the recommendation is to continue with no specific recommendations. Depends obviously on the extent of the IBD and which part of the intestine is affected. But generally speaking, and then of course also the level of activity of IBDs during the flare, for example. But generally speaking, it's more like to help with the symptoms, manage the symptoms, but otherwise no specific recommendations.
Okay, question for in-house. Someone had their hands up.
Yeah, I have two questions, one for each doctor. One is, does the addition of probiotics like through kefir or another product, could that be helpful? And then the second question is, what happens if a PSC patient is diagnosed with an unspecified colitis of like lymphocytic colitis or it literally says unspecified colitis? Do they need to be treated more like the IBD PSC patient, or do they get treated more like the PSC patient a lot? Those are my two questions. Thank you.
Okay, maybe I will start with the probiotics part. So there was actually a study, and it's particularly interesting because obviously there is so much talk and discussion about the gut, liver, and the microbiome. So it makes a lot of sense that probiotics at some point will be recommended if we have the right formulation. So far, nothing that we can really recommend that would change, the course, or there was actually some initial studies that didn't show particular results on the inflammatory markers, on the gut, on the IBD. However, I don't have anything against eating, the kefir or anything if it helps, makes you feel a little better. Just make sure that maybe use the variant, the one that is commercially, available, that is not so high in sugar, but otherwise no concern.
Okay, that's all right.
And for the question about, say, lymphocytic colitis, the treatment is somewhat different. So for if we do a colonoscopy and find that a patient's usually diarrhea symptoms are being driven by lymphocytic colitis, the initial therapy there would be steroids, often budesonide. And if that helps with symptoms and it helps heal that lymphocytic colitis, then no, I don't know that I would necessarily be more aggressive with biologics in that patient. But there are plenty of cases of lymphocytic colitis or microscopic colitis in general that either don't get better with budesonide or steroids, or that recur frequently once the budesonide has been tapered off. In those patients, many of the therapies, biologics that we use for IBD have been shown effective, and often we will use.
One question for you, Dr. Roy. I don't see this often, but people used to get flexible sigmoidoscopy for colon cancer screening. but not these days as much. So what do you think about that? And also the use of, some patients have questions about using the Cologuard card for colon cancer screening. What's your advice for our patients?
I would say in general, if a patient has IBD, neither of those two things would be the chosen colon cancer screening modality. So when it comes to kind of the general risk, the average risk population, the caveats to be considered average risk include not having a family history of colon cancer, not having a condition like IBD. So I think when you have a chronic intestinal inflammatory condition, Cologuard, Flexig, those are not good colon cancer screening options. It should certainly be colonoscopy. And certainly with PSC and IBD, given the heightened risk of colon cancer, full colonoscopies, and even more so, probably full colonoscopies with added modalities like chromoendoscopy, continuing to take the random biopsies of even normal appearing colon. So even that increased level of surveillance, I think, is prudent.
One last question from online, Brian, if you have one. No? Okay, one last question from in-house. Okay, I'm gonna give Joanne the chance, maybe if okay.
I just wonder if Dr. Medici can give me some recommendations on foods I can eat to reduce inflammation.
We have a dedicated talk, by the way, coming up with Dr. Palanisamy on diet and inflammation. But Valentina, if you have a word to say briefly, go ahead. She couldn't hear us. Okay.
Dr. Medici, I wonder if you could just give me some suggestions on nutritional foods I can eat to help reduce the inflammation.
She couldn't hear. Okay. Okay. That's okay. I think we have a whole section on inflammation and diet. Excellent talk coming up by Dr. Palanisamy. I think with that, or Robert, do you have a brief question?
I just had a quick question for Dr. Roy. You clearly showed there was links between IBD and PSC. And what I'm wondering is if someone has a colectomy or removal of the colon, for a liver transplant patient, does that reduce the reoccurrence percentage of PSC?
It's a good question. My suspicion would be yes. It probably does decrease the risk of recurrent PSC in the transplanted liver, but I'd love to hear what your perspective.
Chris, do you want to comment on that? There is a study from international. Oh, she's back online. Okay. Dr. Medici?
Yeah, sorry, I could not unmute. So
Sorry.
I heard, a question, and then there is also a question about banana powder. So in the chat, but generally speaking, a healthy non-inflammatory diet, it's all about non-processed food. So what we always say, instead of drinking the orange juice, just eat the orange. Instead of selecting, I don't know, the banana powder, just select, unprocessed, real food that you can eventually cook from home, and that is basically the anti-inflammatory diet. So that it's and always favor high fiber diet as much as tolerated, making sure that higher fiber diet, it's about 80% of your diet, with a lot of different type of plants that you eat throughout the week. They say at least like up to 30 different type of plant without necessarily becoming vegan or vegetarian throughout the week. That is what it's called essentially anti-inflammatory diet. And instead of choosing, the smoothies, the powders, that just select the real food.
Thank you. Chris, do you want to briefly answer? Thank you, Valentina. There is some data from international PSC studies that shows perhaps colectomy can prevent recurrent PSC. It's not well formulated, but it's some association that has been observed. But PSC Partners has a dedicated research, I think, looking at some of the variables of recurrent PSC, so more to come. So with that, I'm going to close our morning session for lunch. Thank you so much, everyone, for excellent sessions. We'll see everyone back here in about 40 minutes, I think 45 minutes, at 1:35, back to this room. Thank you. Thank you. Thank you.